Okay, well, here we are live. I thought we'd do something from New York since we're going to start topical medical therapy in New York sometime in June or July. We've already scoped that out. Should be right there in Midtown, Manhattan. I wanted to go over a couple things. The International Society of Hair Restoration Surgery had this harebrained idea recently. It's their board of governors. They're a nice bunch of people, but they're absolutely clueless when it comes to follicular unit extraction. And these are the people that, the bus left the terminal 15 years ago on follicular unit extraction, and unfortunately these guys are just now getting on board to train, and they're starting at the caboose. So they had this harebrained idea after hair transplant surgery, follicular unit extraction had been around for over 15 years here in the United States to change the name. And they wanted to keep the mnemonic the same, FUE, but they wanted to change extraction for excision, which is going to be impossible. They did enlist a lot of opinions of a variety of physicians who predominantly don't know anything about follicular unit extraction to ask their opinion. And so all these guys gave an opinion, but the one thing you'll notice that it was this Ricardo Mejia out of Jupiter, Florida, who, you might as well have asked the guy who knows the least amount about follicular unit extraction in the whole entire ISHRS, what his opinion was on changing the name. So he's the guy that came up with this idea to change it to excision from extraction. And he didn't ask a single expert in FUE what their opinion was that I know of other than myself. And I know he didn't publish what I said, and what I said was it was a dumb idea. The ISHRS, the Board of Governors, is very concerned about a practice that's ongoing, and this practice is allowing nurses, predominantly plastic surgeons, allowing nurses to perform the entire hair transplant procedure. And as we know, that's a very dangerous process because it is surgery. There are a lot of things that can go wrong. There are a lot of interactions between medications and the medications that we use and the medications patients are on. A lot of potential complications can occur. It's just plain a bad idea for any surgeon to allow a nurse to perform a surgical procedure. But the fact of the matter is, these plastic surgeons who they think that hair transplant surgery is a Mickey Mouse procedure, and that's because they've never done one. They don't realize how tedious it is. They don't realize how technically involved it is. They don't understand how there's no margin for error when you're taking these grafts. There's no margin for error when you make recipient sites. There's no margin for error when you place these grafts and which grafts you place where on the scalp. How you place the grafts, either on their back, their belly, or their side. They don't understand what it takes to create a natural hair transplant. What they do understand is these plastic surgeons is that they can do a breast augmentation in an hour or two. It's very simple surgery, super simple. They'd be better off to let their nurses do the breast aug than to let them do the hair transplant, which requires a lot more technical skill than their breast augmentation or their liposuction or even their facelifts for that matter. Most of them, they just have no clue. So the ISHRS is very concerned about this practice, and rightly so. And there are a lot of these guys out there, these plastic surgeons and these nurses and whatnot, that market the surgery as if it's not surgery. There's no sutures, no scarring, no wounding, no blood, no nothing. And so the ISHRS feels like now this is the way to stop it, is to change the name to excision so that patients will understand that it's actually surgery. Well, first of all, the ISHRS is blind. Nobody's going to change the name from extraction to excision after over 15 years. And, and that is not going to stop this practice. What's going to stop this practice is patients who go to their medical boards and complain that they were operated on by a nurse. And if you do this, then the medical board is going to listen. And you can go to a malpractice attorney and you can complain to him that you went to a doctor, you had a consultation, and you had no idea the nurse was going to perform the entire surgery. And that the doctor really didn't have a whole lot of experience in FUE or in hair transplant surgery. So if you get the medical boards all riled up and you get the malpractice lawyers involved, that's what's going to put an end to it. Now the other thing that can be useful is if we you know, we go to websites where we know, Tommy, you need to turn that off. We go to websites where we know that you can find physicians who know how to perform a hair transplant. And one of these places is the Bald Truth. You know, Spencer Coburn has, you know, he lists, you know, an enormous number of surgeons who know how to perform a hair transplant, and you can pretty much rest assured that these guys know what they're doing, that they're not going to park you in front of a nurse to do the entire surgery, and that even if they did, at least the doctor knows whether or not the nurse is doing a decent job or not. You know, and again, you know, they're all different levels or layers of physicians. Some are very, very good, and some are mediocre. It's just, you know, it's like being in the NFL. You know, you got cornerbacks that are all pro. You got cornerbacks that are one of a kind, like Deion Sanders, and then you got others that are going to play a year or two and they're going to be out of the league, but they're still all talented and they still all can play cornerback in the NFL. Well, these doctors that Spencer Coburn recommends are all good. They all know what they're doing. There are some superstars, and there are some that frankly aren't as good, but they all reach a certain level, and they're all NFL material. So, you know, that's where I wanted to go with this, this whole concept of changing follicular unit extraction to excision. It's not going to do anything, and the guys that are on board with it, frankly, don't know anything about follicular unit extraction. It's a shame they tried to get involved now and change the terminology. And of course, Ricardo Mejia starts out by acknowledging the follicular unit advancement committee, or back then it was the follicular unit, you know, investigation, the follicular unit community that was investigating follicular unit extraction and trying to find ways how to improve it, not really just the advancement. And the committee that came up with all this terminology was headed up by Parsa Mohibi. He's a great guy, but he wasn't really involved in the definitions. The guys involved were Jose Lorenzo, Bob True, Jean Devois, and myself. And, you know, we spent hours and hours and hours putting all this terminology together to publish in the ISHRS forum for the ISHRS, for their benefit. And it's really a slap on the face to have somebody come along, like Ricardo Mejia, and suggest that we change the name, and then ask Bob True to rewrite it after, you know, we did all this work to write these definitions. And we did it on behalf of the ISHRS. And quite frankly, there was a committee for follicular unit extraction investigation, and now it's advancement. But it was a research committee to begin with. The only body of work that came out of this entire organization, FUE, research committee, that started in the Bahamas in 2012 under the auspices of Jennifer Martinique. But the only body of work that came out of this committee over the last 7 years now, was this terminology, you know, of Jose and Bob and Jean and I put together. And here it is. Ricardo Mejia joins the ISHRS Board of Governors in October and doesn't know anything about FUE, comes along in a matter of months and wants to completely rewrite the definition. It's a slap in the face, and quite frankly, I'm proud to say I'm no longer a member of the ISHRS. I think they're going in completely the wrong direction. Now, the last time we were on, we had a phone call about a medication called tacrolimus. This is an auto. It basically blocks the immune response, and I didn't quite catch the name, and I went back and looked at it, and then I knew what it was. And this medication, we really don't know how it works, but it blocks the immune response, and it does so by specifically blocking the T cell lymphocytes. And certainly, the question was, could this be useful in preventing hair loss? And the answer is yes. The answer is yes. It should be useful in scarring alopecias, and it should also cut down on androgenic alopecia, because anything that inhibits inflammation is going to help promote hair growth, and it's going to be something that promotes hair health and keeps the hair young and youthful for a prolonged period of time. And the goal is hopefully when you're 90 for your hair to look and feel like it's 60. The anti-aging medicine is all about trying to get guys that are 90 to look and feel like they're 60, that they're doing the things that they did when they were 60, and not doing the things that 90-year-olds are doing today, and of course guys and gals. And all men and women start to lose their hair at age 35. So it's very important that in your 20s even, you start thinking about anti-aging medicine for your hair. We do know that your hair ages much quicker when you have androgenic alopecia, and that's why, by age 59, 3% of men are Norwood 7, and by age 70, 10% of men are Norwood 7, and by age 70 to 80, you're going to find somewhere around 23% of men are a Norwood 6 to 7. So you just keep getting older. And so you're trying to put these roadblocks up. Some are Band-Aids, some are very positive. And you're trying to put these roadblocks up to keep the hair as young for as long as possible. So with that in mind, I want to bring over a young man who's been on topical finasteride with minoxidil. This is a product that he got out of Italy when he was visiting there. And he started on this topical medication. I'm just thrilled to death with the stuff we're getting out of Italy and the response that patients are having. Certainly encourage patients to use this product first, because I know it's safe. We're not seeing side effects, and they're responding. So let's pull up those befores real quick there, Tommy, and see if we can get those on first. And then we'll bring young Nick over. Okay. So there's his right side. And remember, he's 21 years old. And let's take a look at the left. And if you look in these temple areas, the left side, not the right again. Yeah. When you look at this, you see that his hair is becoming miniaturized. And it's losing color in these peaks. And it was going to go. And he's 21. We're not even going to entertain a hair transplant on him. We're just going to sit back and wait and see how far it goes. But then, and I'm not a fan of oral finasteride. I don't like it. I don't like the long-term potential for people to have depression or sexual dysfunction or anything like that. So I'm really, really, really excited about the topical finasteride, though, because we're going to get the local benefit without the systemic side effects. I always say, hey, you want to treat your hair follicle, not your gonads. So I don't want to see long-term depression, long-term sexual side effects, decreased sperm count, decreased capacity perhaps to conceive children over time, decreased ability to have and maintain an erection, inability to have intercourse. And I've seen marriages break up over this. I've seen individuals develop depression for a prolonged number of years. I've seen sexual dysfunction that took years to resolve and get better. And we just don't see it with the topical finasteride. And that's what's so exciting about it. We're getting the hair response without the systemic side effects. And the response we're getting is hands down much better than what I ever saw with oral finasteride. So anyway, with that in mind, come on over, young Nicholas, and let's see if we can take a peek and ask you a few questions about topical finasteride. All right, so
Hey guys.
so basically, as you know, Nicholas got started on topical finasteride in Italy, and he did so in December, right?
Yep, in December, late December.
Okay, and so here it is, it's March, and have you seen much of a response?
I'd say saw a huge response.
Yeah.
Temples are right back. Get compliments on my hair every now and then.
Yeah,
Wasn't getting compliments before.
Yeah, pull that left side back a little bit, tilt your head down, and so the whole quality of your hair's changed. Now this side right here, you know, that was all peach fuzz right in there. It's come a long, long, long way. I mean, it was gone, you know, and I was like, he's gonna lose it, and I'm not gonna do a transplant on him. There's no way. He's too young. There's no telling how far this is gonna go. But he's had a nice response. So you getting a lot of compliments on your hair?
Yep.
Yeah.
The barber like, oh, you got a lot of hair still.
And what about, was anybody commenting about your hair when you were losing it?
And when we go to those trade shows over in all over Europe, just go sit down with doctors, and these doctors all perform hair transplants, just saying, oh, come to my clinic, I'll do one for free for you. Don't worry about it. So I'd say I had 20, 30 of them offer me free transplants just so they could use my name for marketing purposes.
Yeah, be a good one there. So, you know, it shows you that the state of our field is that still we got these doctors that want to do surgery on 21-year-olds when in reality, and probably strip too, and when they should be saying, no, you're too young, let's wait and see where this goes. But this is what's so exciting, to have a medical therapy that works. You know, if he were on oral finasteride, I'd be willing to bet that he wouldn't have this response, because, you know, I put 1,000 patients, I had 1,000 patients on finasteride at one time, and I'm sure there are doctors that have 2,000 or 3,000 patients on it, but I just couldn't, you know, I never talked it up the way a lot of doctors do, because I never saw great results, and I did see side effects, and I worried about the long-term consequences. So, but they never responded like this. So have you had any side effects at all?
No side effects, strong as a bull.
Strong as a bull?
Girls still love me.
Great.
Yeah, no complaints.
All right.
No brain fog.
Mm-hmm. No depression?
No depression.
Okay. No other side effects, the kind that men your age don't want to have. So that's great.
Only
that's
more
great.
hair.
Yeah.
That's all I need.
Yeah. It worked well for you. I'm really excited for you. All right. So we're going to do, thank you very much. We're going to, you know, I didn't really want to have this discussion because I talked this discussion from 2003 through 2013. Every meeting I went to, there was somebody wanted to debate me about the advantages of strips over FUE. And, you know, I got sick of that discussion and actually quit going to a lot of meetings, because, you know, what we wanted to talk about was where we were with the surgery and where we were going and how we were making improvements along the way, and where we'd been, where we were, and where we were going. And instead, all these guys wanted to do was take my face and rub it in the dirt and say, look, our procedure, our strips are so much better than what you're doing. And so I just have to get up there and put them in their place. And at the end of the discussion, I'd take their face and rub it in the dirt, because, you know, these guys were doing a surgery that was leaving horrible, disfiguring scars on the back of individuals, and it was distorting hair growth angles, and it was, you know, leaving a tight sensation in the donor area. It was leaving a lot of times a long-lasting permanent numbness or discomfort in the donor area. So patients were embarrassed, you know, they after the procedure, they wouldn't want to go get their hair styled. They cut their own hair because they wouldn't want the barber to see the scar. They weren't getting these amazing results that we were getting with FUE. You know, in general, the scar tend to widen after multiple procedures. And so, did we want to put on a presentation, Tommy?
Yes, sir.
Okay, we can do that. And so we just talked about the aesthetics of the donor area. You go to the next slide. and just basically, good judgment comes from experience. And you know, you're not going to have experience unless you try something. And you're going to make mistakes along the way. There's no question. Which is why I get concerned about doctors that have just started doing FUE. You know, they haven't made the mistakes. And I know for sure they didn't listen when we were trying to tell them what to do and what not to do 10 years ago or even 5 years ago, because they didn't start doing FUE until recently. And it scares me a little, because it literally takes somebody about 10 years to become an expert in any surgery, and then only if they do it every day. But I predicted in 2003, that it would take 10 years for the majority of physicians to accept FUE. And that didn't mean that they were going to jump on board and suddenly switch their practice. It meant they were going to start offering FUE. And you know, Walter Unger said it, that one of the most serious complications of hair transplant surgery over the past decade, and he said this back around 2000, was the post-operative development of cosmetically embarrassing wide donor area scars. And this is the physician that wrote all the textbooks. And here's an example of some scars. You can, you know, even with the trichophytic closure, you get an ugly scar. You get widening of the scar. You can get where scars turn red or pink, and there was no solution for that red scar. There was no solution for a pink scar until we discovered that putting hair into the scar would actually help change it. But there's no way to put this donor area back to normal. It's impossible. You can go to the next slide. You know, the hair on the scalp flows in a pattern. You know, and when it does that, it helps to cover and converge and come together. And so when you look at the when you look at the hair, it comes down and flows toward the midline from the right to left, and then from left to right flows toward the midline. And some people have more extreme flow patterns. But when you do a strip, what you've done, you go in and you take out that area. And I've always said it's like going into a church and you see a nice mosaic, let's say Madonna with baby Jesus, and she's holding that baby in her arms, and the surgeon goes in there with his scalpel and he cuts her here, and he cuts her on her belly. So he chops out from her neck down to her belly, takes out the baby Jesus and everything in between, and starts chopping it into individual pieces of mosaic to spread out and make a new design. And then he drops the head down on the waist and sews it together. So you've cut out the natural flow. You've just completely destroyed the mosaic. Whereas follicular unit extraction is like going in and taking out one piece of that stained glass window at a time, and then taking that and moving it to another place to tell a different story or a new story there, but without completely destroying the anatomy and the design and the flow of the original story that was there. You still can see the Madonna and the baby Jesus with FUE, whereas you know you just completely ruined that entire image with a strip surgery. So when you take out the strip, you alter the hair growth directions. You mesh directions. You're going in two different directions, and that's kind of a mess. Let's see. Going this way. You might have to advance me here, Tom. I got a mess on my hands here. I'm staying the mouse.
I got you.
Go. Okay, so we'll go back one. No, back. There you go. So you can see here that above this strip scar, the hair's growing forward. Below the strip scar, the hair's growing down. You can't fix that. There's no way. You can come to me, I can put hair in your scar, but I can't change this anatomy. It's destroyed. And it's a different color. You know, the hair above is darker and coarser, the hair below is finer and lighter. It's a real mess. Next. Okay, so this is a center of a strip scar, and it's really, you know, came together really nice, but when you look at this thing, you can see the hair on the left is curved. You know, that's because it's curved to grow up and out, and the hair above it, that's above the scar. And that's still got its normal downward direction. So the hairs are growing in two different directions. This ugly picture, this strip that some doctor took, you know, about 1.5 centimeters, 2 centimeters wide, with all that hair in the middle, and you got to sew that up. It's going to leave him feeling all tight and everything. It's just a mess. Okay, so what happens, especially in people with fine hair, is the hair below the scar starts to grow straight out. And I call it a horse's tail, and it makes guys look like they were wearing a cap. You know, that their hair pooches out like that, and they just took the cap off. But it's like that 24/7. And the reason is all the different directions of hair growth. Next. And there's a horse's tail. So that's below the scar, and you can see how the hair gets pulled up like that, and it rises up, and it's supposed to grow down, not up toward the top of his head. And that's what strips do. They distort the anatomy, and they do other things too. We're going to talk about it. We just move on. You see how they distort the angles? You know, the hair above is not growing in the same direction as the hair above. You can't fix this short of pulling those hairs out. Look at this. You know, the hair below is in one direction, hair above is in another. Next. And look at this. This is a single strip. The patient got a perfect scar. And what the doctor did, in his infinite wisdom, was he married two different types of hair, coarse hair, dark hair, with fine hair, light hair, going in two different directions. You know, there used to be a natural transition here. But when the doctor went in and pulled out his 2 centimeter strip, he married two different directions, two different types of hair, two different colors of hair, it's growing in two different directions to one another. He made it so this individual is going to have a problem the rest of his life, and there is no easy solution. Sort of taking out everything below and putting it back in so that it goes okay. This is, you know, this is what we started to see in 2003, that we could go in, do 2,500 grafts, and this would be the donor area after 1 week. There'd be no strip scar. And it would look even better than this after a month. Move on. So, you know, FUE is really the opposite of grafting. It's instead of adding 1 Flicker unit at a time to the recipient area, we're removing one at a time. And the ultimate goal is to get it where the density and the sides and the back is the same as that in the top. Okay? Next. And this is an example. This is close to 10,000 grafts right here. You know, 9,491 to be exact. And this is a patient where we look at the cross-sectional trichometry in his donor area, and over time this went down to a 54. But what happened was the top, the front, and the crown all went up. So once all the cross-sectional trichometries are relatively close, it's game over. We either going to move into beard hair, and if you're lucky, you know, if it grows, like chest hair only grows in 1 out of 4 people, but we can move it. Beard hair works pretty well in everybody, although the yield can be 60% in some, but it grows much more consistently than chest hair. You know, once the cross-sectional trichometry is similar throughout, it's done. That's as far as we can go without another source. So you can see the donor area looks good, top looks good. He's definitely thinner in the donor area. A little bit of hyperpigmentation, but in general, no strip scar. Go on. And he had 50 grafts per square centimeter, which is nice. So then he pushed me to 10,600 grafts, and I said, you know, that's too far. And we did it. You know, he did okay. To me, it made him look a little bit thin in the donor area. And so we wound up taking a little beard and putting it in the donor area to make that all look better. And of course, we can do micropigmentation, scalp micropigmentation in the donor area. There's little tiny tattoo dots to help improve that coverage there and yet take more hair. But we went a little far, and I told him I thought we were going too far. He wanted to do one more pass. And that was the end of it. We didn't try any more with him out of this donor area. Just 5,000 grafts out of the donor area, and you can see it healed beautifully. And this is what got me in 2003 to stop doing strips. You know, I started looking at donor areas, and I said, oh, we could get much better results. We get better coverage. We get better coverage with fewer grafts than we can with strips, and we don't have the strips going. And one of the problems you have with strips is they thin out over time. You know, you can have a great result today, but down the road, you know what happens? Your transplant thins out. And the answer is why? You know, why does that happen? And it's most likely because strip surgery is subfollicular unit transplantation, where the nurses split the follicular units into more than one graft. In other words, they may take a 3-hair follicular unit and split it into a 1 and a 2. And when they do, they separate some of those hair follicles from the stem cells necessary to regenerate multiple cycles. And that's the theory of Andy Messinger, that first end have the stem cells that give rise to the subsequent hair follicles. And those are the second end hair follicles, secondary hair follicles. So the primary hair follicles give rise to secondary. Well, if your technicians, your nurses, are splitting grafts and they're splitting the primary hair follicle from the secondary hair follicle, eventually you're not going to have the stem cells necessary to regenerate those grafts. And so it's one of the reasons why we see strip surgeries that look great, you know, for the first 5 years start to look terrible. And so, you know, it's hard to get this through the heads of these strip surgeons that they're doing a lot of harm to the donor area and to the recipient area, but they just don't seem to get it. They just don't, you know, in general, the physicians that are still providing strips day in and day out, they're not your brightest physicians, okay? They're not the rocket scientists, they're not the leaders in the aesthetic field of hair restoration surgery. They're the followers. But it doesn't mean they're bad guys. It's, you know, we do need followers as much as we need leaders to maintain a level of sanity, but they don't think about the consequences of what they're doing. This was an early procedure we did. This was like 2004, 5,700 grafts from a couple of passes. And we refilled his donor area with leg hair. And we subsequently found that leg hair wasn't a great source because it can fall out after, you know, in your like 5th, 6th decade. But it really helped hold his donor area and shave down and got a nice result. Next. This is like the nail in the coffin. You got to go back. This is the nail in the coffin for me with strips. And it was like, this is the one that most strip surgeons still haven't acknowledged. Okay, it's like what you're doing, folks, when you do a strip is you're killing hair. And you know what? When you have hair loss, that's the last thing you want to hear. And these surgeons who are doing strips day in and day out are applying a traction alopecia, or applying traction to the donor area, and the consequence is a traction alopecia. So I did this study, and we did it in a number of patients across the board. And what we found was that when we did FUE by itself, we would see a slight drop in the cross-sectional trichometry of the donor area. Not much, a little bit. But when we retrospectively studied patients who had strips, we found that the average cross-sectional trichometry in the donor area, which was around 70 before surgery, dropped to around 52 after surgery. So we're like, whoa! You know, after FUE, it's dropping to 67, 70, maybe 64 on some really big cases, but average 67. After strips, the average was 52. And what is cross-sectional trichometry? It's a measure of density and diameter. It's the number, you know, when you think of it like this, it's a box of spaghetti noodles. And in that box, you could have 100 noodles. and then another box you're going to have maybe 80 noodles. And if they're the same size, same diameter, same type of spaghetti, one has 80, one has 100, the box with 100 is going to have a bigger number, and the box with 80 will have a smaller number. Well, you could have two boxes with 100 noodles, and one of them's angel hair pasta and the other one's fettuccine. Well, you measure those two, and you're gonna say 100 fettuccine is going to be much bigger than angel hair pasta. So Corsair is going to give you a bigger number. A higher density is going to give you a bigger number. But after multiple strips, we found that it was taking all these noodles out of the box, and it really didn't matter. Diameter wasn't an issue. When we looked at the diameter of all these cases, we found that in strip surgery there was a small drop off. It went from 72 micrometers. You know how small that is? It went from 72 down to 69. That's less than half the width of a red blood cell. Really tiny, a very small drop, and it stayed the same with FUE. So with cross-sectional trichometry is a measure of density and diameter, what we looked at was the hair density. And flicker unit density remained the same. It didn't kill off flicker units, it just killed off hair to do a strip. So the hair density dropped from 186 in a virgin scalp per square centimeter down to 167. But it stayed at around 182 after FUE. You expect the hair density to go down, right? You expect the flicker unit density to go down with FUE. But you know what? It dropped off big time with strip surgery. Small drop with strip, whereas flicker unit density was the same for strips in FUE. But what really happened was the cross-sectional trichometry dropped off with strip surgery because of traction alopecia, and the strip was killing hair over time. So not only do you have to leave more hair in the donor area to conceal the strip scar when you do a strip, you're going to have less hair in your donor area for subsequent surgeries because strips kill hair through traction alopecia. Say no to the strip. Next. Okay, now this is the bad part of FUE, is that we can get some hypopigmentation, and that hypopigmentation can be larger than with a wound. We might use a 0.9 millimeter punch, and people that are prone to get hypopigmentation might get something that's in this case it's 1.79 millimeters, which is half the radius, which is basically the radius of this circle. Next, but we have some tricks. And one of those tricks is to put A cell into our extraction sites, and here you can see a little drop of A cell in this extraction site. Next, and when we do it, and not everybody gets hypopigmentation, but when we take this A cell and we mix it in hyaluronic acid, and we put a little drop of this, you can see these little A cell particles in this hyaluronic acid, and put it in those extraction sites, guess what? We get improved healing, we get follicle regeneration, and we get a reduction in the hypopigmentation. So the hypopigmentation is less. So when patients get it, it's smaller, and it's no longer 1.79 millimeters. It's much less, maybe half of that. And so we get better healing. And not everybody gets hypopigmentation, but some do. In this example of a patient, we went in, we took, we removed. We always calculate exactly how many flicker units we removed. This was an Asian patient, and we took out a total of 2,378. It looks like a total of 17% of his donor area. 17% of his safe donor area, which is 203 square centimeters. So we calculate the number, the percentage, and we do it for every region in the donor area. But what's one value to doing that? Look in the next slide. Is we can go back and we can count any hypopigmentation we see. So this is after 2,500 grafts. We can go in and put a dot on the hypopigmentation with an counter that we have that doesn't make mistakes. And we see an average of 48% of these extraction sites we can't find when we use ACell. And and I go in and I look at it, and we're sitting in it right around 30-something% have at least one hair follicle regenerated in the extraction sites. And I have to go over that study because it's really interesting where we actually tracked individual extraction sites over time and followed the regrowth of the follicles due to ACell. It's really exciting. And why does it work? Well, you know, we do a minimal depth extraction. So we try to leave stem cells from the upper to the interior. And recently we actually started doing something else. We started adding follicle stem cells back into the A cell. So when we put it in the donor area, and that healing was, I mean, my God, it was unbelievable. You know, you barely find extraction sites on these guys. So I think that may be the next step, is to add follicle stem cells to the A cell, back in the extraction sites. And it's pretty exciting. I have to show that case to you. Next. So what adds, you know, what are we looking for and what causes hypopigmentation? Well, there are a lot of things. One is the wound itself can heal white. You know, and not everybody gets it, but when you do, you do. Well, we can put a little dot of micropigmentation there and take care of that. But there are other things that cause it. It's when you look at these follicles, you look at the surface of the skin, and then you can see below it. You can see this little shadow, this little color, and this color is, you know, is indicative of a follicle that's in anagen. Only hairs that are in the active growing phase will have this color. And unfortunately, I don't have a pointer to show you, but this, you got a pointer over there?
Yeah, it's not
Is your
showing.
pointer? It doesn't work?
No.
This shadow adds color to the donor area. And the next is these little blood vessels. You can see these little tiny capillaries are in there. How's your pointer? You get it up and running?
No, I'm trying, but it's not showing.
Okay. Well, anyway, these little capillaries, you know, when you take the extraction site out, that you no longer need circulation. So, you know, you wind up with a white dot. And it's circulation, it's pigment in the skin, melanin that heals with white due to scar formation. It's the shadow that's there from the anagen follicle. And next. We put A cell in there, and what can we get? You know, even if we don't get follicle regeneration, we can get, you know, normal appearing skin. You know, we get the melanin, we get the circulation, the vascularity, and it just looks like normal skin. Next. And we can get like compression of scars. Next. Okay. So in the extraction study, we see, you know, in this particular case, 54% of the extraction sites had regrowth of hairs. And this is looking at individual boxes and looking at the number of extractions and the number of hyperpigmented spots and taking the difference. Next. This is safe donor area, and on. And we'll just finish her up. Just again, going back to what happens with age is that the percentage of men that are going to go to a Norwood 6, which is really a lot of hair loss, or Norwood 7, it increases with time. And, you know, you're going to wind up with 30% by age 80. And 3% of men will be in Norwood 7 by age 59. So it means that we can go up high on the sides of the donor area and out of what strip surgeons may call the safe donor area. And most of these individuals, because only a small percentage are going to move to a class 7 by age 59. And guess what? You can see those guys coming when they're 25. You have a pretty good idea at age 25 when you have excessive loss. Different parts of the donor area have different types of hair follicles. So if we're looking for fine hair, we're going to go low. And we're going to look for hair groupings that have more hair, we're going to go high. And if we're looking for easy hairs to get out, it might be in the middle. There's different types of skin in the donor area. There's elastic skin, there's loose skin, there's hard skin. I mean, it's all different all over the donor area. We're not going to get into that, but that's why we always map it out, because we can definitely distinguish what's going on. This is an example of what not to do in FUE. I made this mistake in 2003 by harvesting hair in a shaven patch, and that's why I've told physicians since 2003 not to do it. But Sometimes they don't listen, like Jim Harris in like 2008 or 9 did a shave and patch after I told him don't do it in 2003 because I already did it and it looks worse than a strip scar. But he turned around and did it. And sure enough, unhappy patient, I wound up repairing the guy. All right, next. You can get great donors areas with FU. This is 3,000 grams. So that's it. And if there's any dun, 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 dun.